Welcome to the Non-Emergent Evacuation Overview course. The objective of this course is to describe the pre-evacuation actions that should be accomplished, the process for classifying patients based on their mobility level, and patient preparation activities. The program begins with an overview of non-emergent evacuation and concludes with a discussion of patient discharge procedures. There are two types of non-emergent evacuation: urgent and planned. An urgent evacuation occurs when remaining in the present location is not possible, but the threat is not so great that emergent evacuation procedures are needed. Instead, a small amount of time exists for planning and resource mobilization. Circumstances may arise that potentially render the environment of care unsafe or inhospitable, or that may adversely affect the provision of patient care or ancillary services. Examples may include a physical plant problem, such as a midwinter heating failure, an environmental challenge, such as a prolonged rainfall resulting in flooding potential from a nearby river, or a mission-critical system problem, such as a sewer blockage, that is not correctable within a short time period. In such a situation, evacuation must commence within a brief time, for example, 4 hours, in order to maintain a suitable environment to allow a unit or department to fulfill its mission. In the meantime, the affected organization will explore or implement alternatives to evacuation to obtain more time for an orderly evacuation process. A planned evacuation takes place when circumstances are anticipated that require relocation of patient care or ancillary service activities within at least a 48-hour notice, or where ample time exists to inform patients, families, and staff, plan activities, mobilize resources, and control the relocation without extraordinary measures. Example scenarios include a planned alteration of the physical plant or an impending hurricane. This type of evacuation normally is anticipated several shifts to days in advance, and if properly planned and coordinated, should not require extensive public safety or mutual aid resources. Time criteria will allow non-emergency ambulance or other resources to provide required transport of patients between temporary locations or other facilities and the hospital. An emergent evacuation generally transitions to an urgent evacuation at the point where the immediate danger to life or health dissipates sufficiently so evacuees can pause, regroup, and develop an interim plan for a more orderly course of action. In both urgent and planned evacuations, the steps in the process and the sequence of events are the same. The principal distinction between the two types is the amount of time the organization has to mobilize resources, activate agreements, and develop incident action plans, arrange for suitable patient destinations, and carry out the evacuation. It is important to note that for planned and urgent evacuations, the process described relates to relocation of hospital inpatients only. By definition, situations calling for urgent and planned evacuations provide sufficient time for the release of outpatients and same-day procedure patients, as well as for the routine clearance of non-patient care areas. For an urgent or planned evacuation, a number of procedures should be implemented at the direction of the incident commander to enhance the success of the evacuation operation. Depending on the lead time available, the specified actions may take place concurrently or be scheduled over one or more operational periods, which could last hours to days. The process begins with the incident commander communicating with stakeholders the decision to evacuate the facility and the time available to complete the evacuation. Next, the incident commander ensures that the emergency operations plan and hospital incident command system are activated and staffed appropriately, and the hospital command center is operational. Upon assignment, command staff should review the facility and departmental emergency operations plans and procedures. In addition, they should initiate a full census of patients and movement equipment using the hospital's status reporting process. Each floor or unit should provide this information directly to the hospital command center and provide an update every 4 hours for the duration of the emergency. Next, incident management leadership communicates the decision to evacuate throughout the hospital and to all stakeholders, oversight entities such as the health department, response and recovery assets, and the local media. Timely and accurate information sharing across the organization is crucial to managing an evacuation effectively and with reduced apprehension. The liaison officer from the command staff notifies EMS communications as soon as a decision regarding evacuation is reached. Contingency staffing schedules should be prepared and implemented. This includes considerations for which staff remains at the hospital, which staff goes off duty or rests now to return for duty at a later time, and which staff relocates or reports later to an alternate or secondary location. Incident management leadership should begin considering implementing their emergency department diversion policy when it is anticipated that much of the hospital's efforts and resources will be focused on evacuation rather than patient care. During an urgent evacuation, total diversion should be implemented at the outset of the incident and communicated to all stakeholders as well as the media. In a planned evacuation, diversion status should be limited to EMS traffic only whenever possible. Efforts should be made to quickly evaluate current patients in the emergency department for potential discharge. The emergency department charge nurse should coordinate this with the attending physicians. In either situation, staff should be retained in the emergency department, despite your diversion status, to tend to the emergency medical needs of the community, as well as any responders, staff members, or patients whose conditions require immediate care during the evacuation. An EMS vehicle and crew, if available, should stand by at the emergency department to stabilize patients arriving from the community and transport them to an open facility. Begin canceling elective procedures scheduled for the affected days, and notify impacted patients that their procedures will need to be rescheduled. Depending on time, discontinue, conclude, or make other arrangements for procedures already underway for patients in same-day surgery, ambulatory care, outpatient dialysis, and clinics. Finally, cancel visiting hours and ask current visitors to leave the facility, and advise them how to obtain information on the patient they were visiting. Some visitors should be allowed to remain, including parents or legal guardians for minors, translators, and healthcare proxy for patients without decision capacity. Consideration should be made for compassionate need of patients on a case-by-case basis per hospital policy. Obtain and secure cash for emergency payments. Experience has shown that during a crisis, and especially a community-wide emergency or an event with associated loss of power, a cash-only economy often develops. For example, cash may be needed to pay taxi service or for other vendors. Appoint a bed tracking manager in the planning section to begin identifying available patient bed destinations through direct contact by telephone or through established local protocols or coordinating regional bodies. Patients who can be discharged to home, long-term care, home care, or to caregivers should be identified and readied with the help of case management. Reconfigure and staff an area of the emergency department to serve as a stabilization or holding point for stretcher-bound patients. Designate one area of the ED to treat ill or injured staff and rescue personnel, and patients arriving from the community who were not or could not be redirected. Redirect incoming vendor shipments to alternate destinations, or reschedule the deliveries. Create a perimeter for security and traffic control in conjunction with local law enforcement authorities. The perimeter should identify traffic control points, staging areas, access checkpoints, and reporting locations for staff. In addition, establish hospital supply truck routes and patient evacuation routes. Clear parking lots as needed to accommodate evacuation vehicle staging. Establish 5 departure staging areas to assemble various types of vehicles designated to move discharged and evacuated patients, as well as transport medical support equipment to receiving facilities. These departure staging areas, managed by the logistics section, need to be strategically located on and off hospital grounds for easy movement, and should correspond with the 5 loading areas that will be discussed later. The departure staging areas include ambulance staging for stretcher-bound patients, medical transport vehicle staging for specialized vans and minibuses that can transport wheelchair patients, walking ambulatory transport vehicle staging for buses, cars, and vans that can move patients who can walk on their own, discharge pickup staging for those patients being picked up and taken home, and equipment transport vehicle staging for trucks that can move hospital beds and other equipment. The departure staging areas should be pre-planned, secured, and clearly identifiable. Assign a staging area manager to set up and staff each area and be equipped with a portable radio. Create, staff, and equip 5 loading areas on the main floor to stage patients and equipment that are ready for departure. Logistically, these loading areas should be strategically positioned throughout the facility near different exit points that allow transport vehicles to move easily into and out of the area with as little downtime as possible. Click on each loading area to learn which sections of your hospital to consider. Initiate the bed and medical equipment relocation process. As beds and medical devices are made available at the patient loading areas, they should be brought to the equipment loading area to be redirected back into the hospital, or transported to alternate destinations as needed. The supply unit leader from the logistics section is responsible for coordinating these medical equipment resources. The equipment loading area manager, who is assigned to assist the supply unit leader, should ensure that all equipment leaving the facility is inventoried, labeled with the hospital name and tracking number, and documented on an equipment relocation form. When readying patients for evacuation, they must be appropriately prepared and sorted to optimize their movement and ensure proper allocation of resources. The traditional practice of triaging patients based on their medical needs or injury severity is not as helpful during an evacuation, since the problem at hand is not prioritization of treatment. Rather, the priority of evacuation is maximizing the efficient use of limited resources to move patients, such as personnel, evacuation devices, and transportation vehicles. Consequently, patients should be categorized by how mobile they are, which helps determine the type and amount of resources required for their evacuation. For example, a patient in a wheelchair requires only 1 staff member to move them from their room to the holding area on their floor. An ICU patient, on the other hand, will require several staff members to move the bed, ventilator, and assorted IV pumps. For evacuation, patients should be divided into one of 3 mobility levels: walking, wheelchair, or stretcher. A patient's mobility level determines the number of staff needed to move the patient, the type of movement device required, the loading area where they are to be relocated, the type of transportation asset desired, for example, a wheelchair, stretcher, or evacuation sled, and the destination facility where they are to be transported. A proven practice is to routinely determine each patient's mobility level and record it in each clinical department or unit whenever the emergency operations plan is activated for an event with evacuation potential, such as a fire alarm. Document the mobility level on each unit's emergency status report form and forward it to the hospital command center, where the planning section collects the data. When determining the mobility level of a particular patient, there are 3 essential elements to the process: assessing and classifying patients quickly and accurately, marking and tagging patients in a consistent manner so that other staff can easily recognize the designated mobility level, and documenting and reporting the patient's transport versus discharge status for resource acquisition and tracking purposes. A commonly deployed method for identifying a patient's mobility level is to use either a pre-printed, self-adhesive identification wristband or a piece of colored surveyor's tape secured to the patient's wrist. Whichever type of band is used, they should include the following: solid bright colors of green, yellow, and red for patients to be transported to a secondary location, as well as white striped ones for those patients earmarked for discharge. In addition, a solid blue band is used to identify those patients requiring special attention or observation during the evacuation process due to potential behavioral concerns, security issues, or special medical needs. The appropriate colored band or bands should be secured around the patient's wrist. There are 3 mobility levels used to categorize patients for evacuation. The first is walking. Walking patients are those who are able to ambulate the distance from their inpatient location to the designated walking ambulatory loading area on the main floor without physical assistance and without any likelihood of resulting harm or impairment. These patients are identified with a bright green wristband, then triaged for evacuation. Ambulatory patients should always be escorted by staff members, but may be moved in groups, led by a single, non-clinical provider. The optimum staff-to-patient ratio is 1:5. Ambulatory patients can be transported as part of a larger group in a passenger vehicle, such as a bus or transport van, with a single staff member or EMS provider accompanying them. Wheelchair patients are those who are alert, but unable to walk the distance required due to a physical or medical condition. They are clinically stable, without any likelihood of resulting harm or impairment from wheelchair transport or prolonged periods of sitting. They do not require attached medical equipment or medical gas, other than oxygen or a maintenance intravenous infusion during their relocation or evacuation. These patients are identified with a bright yellow wristband when triaged for evacuation. They can be safely managed by a single non-clinical staff member. Wheelchair patients can be transported as a group in a wheelchair-appropriate vehicle with a single staff member or EMS provider accompanying them. Stretcher-bound patients are those who are non-ambulatory, requiring transport by hospital bed, gurney, or stretcher. These patients are clinically unable to be moved in a seated position and may require equipment ranging from oxygen to mechanical ventilators, cardiac monitors, or other biomedical devices to accompany them during movement. They require clinical observation ranging from intermittent to one-on-one nursing. For emergency movement downstairs, they may have to be transferred to evacuation sleds or similar equipment, stretchers, backboards, or rescue dragged on their mattresses. These patients are identified with bright red wristband when triaged for evacuation. Stretcher-bound patients require a minimum of 2 staff members, 1 clinical, 1 non-clinical, for movement, with additional staff as needed to manage life support equipment. These patients require an ambulance or specialized vehicle for transport and must be accompanied by a clinical provider appropriate to their condition, such as an EMT, paramedic, or clinical staff member. Although stretcher-bound patients are all non-ambulatory, their level of acuity and support needs can vary widely. This variation impacts resources needed to move the patients, the order in which they are evacuated, and the type of bed placement and facility they require. To better visually demonstrate the acuity differences within this mobility group, especially during large-scale evacuations, it is often advantageous to group these non-ambulatory patients into 5 subcategories for evacuation. All of the following subcategorized patients have the same bright red color band, as all are in the same mobility level, but the number of red bands placed can distinguish them. Lowest acuity. These patients are clinically stable, but must remain in a lying down position. Examples include patients with altered mental status, blood pressure instability, neurological impairments, or orthopedic conditions that preclude them from wheelchair transport. This subgroup of stretcher-bound patients should be moved together and can be identified by applying one red band to their wrist. Moderate acuity. These patients have stable vital signs, but are at increased risk of deterioration. Examples include post-operative patients, or those who require biomedical equipment to accompany them. This group of non-ambulatory patients is moved next, and can be sub-identified by applying two red wristbands. Critical care. These patients have unstable vital signs, require invasive monitoring or other life support equipment, and are at greatest risk of harm during evacuation. Defend in place should always be considered as the best option for this group. Any movement should be as a last resort, when the risk of remaining outweighs the risk of evacuation. 3 red wristbands can be used to quickly identify this group. Interrupted procedure. These are patients who were in the midst of an operative or other invasive procedure, which was interrupted to effect an emergency evacuation. In addition to their critical care status, these patients may need immediate relocation to a suitable operating suite for procedure continuation or other measures. 3 red bands will clearly identify the critical nature of these patients. Arm carry. These are the neonatal, infant, or child patients who have stable vital signs, do not require life support equipment, and can be safely arm carried without adverse health effect. These patients are categorized as non-ambulatory, lowest acuity, and would have 1 red band applied to their wrist or ankle. Others whose hemodynamic status is questionable, or neonates and infants who require incubators, would be classified as either moderate acuity or critical care. Regardless of their primary mobility level designation, walking, wheelchair, or stretcher, patients requiring additional support or attention during the evacuation should also be triaged with a bright blue wristband. This special observation needed designation alerts staff of particular patients who may require increased behavioral health or security support, infection control practices, or unique destination selection to help ensure the safety and success of their evacuation. For patients being discharged, the mobility level wristband used should be the appropriate mobility color, brightly colored green, yellow, or red with white stripes. All other patients not being discharged will be designated with tapes in solid colors. During a non-emergent evacuation, individually prepare patients for movement based on the following sequence of events. Depending on the lead time available, these actions may take place at the same time, or be scheduled over 1 or more operational periods, which can last hours to days. These are patient-centric, unit-based actions carried out under the direction of the specific patient care area's evacuation group supervisor, who is typically the nurse manager on the floor. Begin the evacuation process by informing patients and any family members present of the reason why the hospital is being evacuated and what the patient's continuity of care plan will be. Inform patients identified for discharge that the reason for their early dismissal is to reduce the number of patients needing to be evacuated. Communicate a care plan to these clinically appropriate patients. Confirm the patient's identity via the hospital name band and the corresponding medical record and with the patient directly, if possible. In consultation with available medical staff, determine the mobility level of each patient and decide which patients require evacuation and which ones can be discharged. Affix the appropriately colored band from the unit's evacuation readiness pack to the patient's wrist to denote their mobility level. Where possible, place babies and mothers together for the duration of the evacuation. In circumstances when traveling together is not possible, be certain to communicate with the family the baby's current location and time frame for movement and arrival at the receiving facility. Next, prepare patients being discharged to home or other disposition for departure in the usual manner. Allow family members and visitors to remain with the patient at the discretion of unit leadership under the following conditions. Their presence does not hamper or impede evacuation efforts. They are not at greater personal risk by remaining in the facility. Their presence is helpful in calming the patient, serving as a translator, or facilitating the move. And they are parents or legal guardians for minors or healthcare proxy for patients without decision capacity. Prepare an expandable document evacuation go pouch for each patient to carry essential, patient-specific medical information. Use a permanent marker to write the patient's name on the pouch and to complete any associated evacuation information and tracking forms used by your institution. The tracking form used should include a listing of the patient's primary and secondary diagnoses, medications prescribed and associated allergies, advance directives, and other vital information to ensure continuity of care whenever possible. Compile all components of the patient's medical documentation, including the medical record, medication administration record, treatment administration record, etc., and place them into the evacuation go pouch. If the facility is using an electronic medical record, the key elements of the record should be printed, if conditions permit, and brought with the patient. If that is not possible, alternatives include providing the data in an electronic format or providing data access to staff at the remote destination. Assemble all of the patient's medications other than controlled substances and place them into a gallon zipper closure medication bag. Affix a patient identity label and insert the bag into the patient's evacuation go pouch. Only essential controlled substances should be sent with the patient upon evacuation, such as lorazepam for an uncontrolled seizure patient. Insert additional priority medical supply items, such as tracheostomy tubes or special dressings, into the pouch as well. Comfortably affix the go pouch to one of the patient's extremities using tape or ties. The pouch and its contents must remain with the patient throughout transport until the patient is admitted at the receiving facility. If there is no way to physically secure the evacuation pouch to the patient, position it under or between the patient's legs on the movement device. Consider changing all maintenance intravenous infusions to saline locks. Assess all other supportive biomedical equipment and devices such as an infusion pump, feeding pump, etc. for discontinuation. Place a portable medical oxygen cylinder at the bedside of each patient who will require medical gases in transit. For patients on ventilators, a bag valve mask, or BVM, must be provided at the bedside. If there is insufficient oxygen available, medical triage procedures should be followed for prioritization of need. If time permits, ensure that all equipment leaving a floor or unit is labeled with the hospital name, point of origin, and tracking number. Prepare an inventory tracking list for all equipment being removed. During a facility evacuation, it is important to try to reduce the number of patients requiring evacuation. This may be accomplished through early discharge of those patients who are clinically appropriate. The discharge planning process includes identifying needed referrals or transfers to another provider or level of care when continuing treatment is anticipated. During the evacuation from the facility, the following levels of care should be used: home with no aftercare needs, home with home care, or transfer to skilled nursing facility. The inpatient unit leader under the medical care branch director from the operations section is responsible for coordinating the discharge planning process during evacuation. This coordination will often require social services assistance from case management and medical input and direction from a member of the physician assessment strike team. This team of physicians is assigned to provide expedited clinical decision-making and decision support in the event of an evacuation. Their primary function is assist nursing staff when necessary in making decisions related to patient mobility level, immediate discharge determinations, or transport decisions. They may also be called upon to make emergent clinical interventions. Depending on the number of strike team staff available, the team members may visit the units, provide telephone consultation, or use other alternatives to make recommendations. At a minimum, the physician assistant strike team should include a senior hospitalist who serves as the team leader and assembles the necessary team members. The maximum number of patients for discharge or transfer should be identified through the status reporting process that occurs on each patient area whenever the emergency operations plan is activated. Patients who can be discharged will be prepared and delivered to the discharge patient location as identified in the facility's plan. The inpatient unit leader should monitor the ability to complete the discharge and may direct the movement of these patients to an alternate safe location until they can be picked up. In this course, we have presented the process of preparing for an urgent or planned patient evacuation, beginning with pre-evacuation actions, and continuing with patient preparation for departure or discharge. In a subsequent course, we will review the actual flow and sequencing of patient movement during a non-emergent evacuation and address various recovery considerations.